everybody. Thank you for coming out. My name is Cherie Cora. I'm one of the radiologists at Loma, and I specialize mainly in breast imaging. So today we're going to talk about breasts, about breast screening, about some imaging, probably more than you ever wanted to know about breast screening. So why is breast cancer screening necessary in the first place? As you can see, it affects everybody, regardless of race, creed, and it's a fight that we've been going on for a while. And we are trying to not only find a cure for cancer, but we're trying to diagnose cancer as early as possible so people can get the best treatment. Before we go into the actual screening, I'm going to speak for a moment about some breast anatomy. So this is a picture of someone's breast looking from the side, and you can see that you have a nipple, the colored part around the nipple, the areola, lots of yellow in the middle, which is a mixture of fat and the fibroglandular tissue that makes up everybody's breasts. Within that, there are several little lines. Those are the ducts that everyone has in their breasts for breastfeeding. And at the back side of those ducts, you have lobules. That's where milk is made. And I give you this information because I will refer to some of these areas at a later time. So when you go and people tell you you have a biopsy and you get a result, sometimes you get something from the pathologist that you don't understand. So I'm going to give you a quick lesson in pathology, which is not all that interesting. But if you took that same breast that you had earlier and you took one of those ducts and you cut it in half like a straw and you look down the straw, you would get those pictures that are on the right-hand side of your screen. So a normal duct has cells surrounding it, and it has a little purple line. It's not really purple in real life, but a line around the edge which keeps them all in place, basically. That's what a normal duct would look like. You go to the second duct, and you see that on top of your normal cells, there are a few small cells that are there in addition. That's where there's duct hyperplasia, meaning increased growth of cells there. Now, it's a spectrum. If you keep going to the third picture, you see more and more of those little cells on top of the normal cells. That's atypical ductal hyperplasia, long term for saying something's not quite right, but it's not cancer. Okay? You continue down an increased number of those atypical cells. At a certain point, the pathologist who looks at this with a microscope says, this has crossed the threshold. This is now what's called ductal carcinoma in situ, meaning cancer within the duct. Okay? Sometimes you can get a little bit of movement of the cells outside of that purple line that's holding all of the things together, and that's called ductal carcinoma in situ with microinvasion, just a little bit outside the line. However, what you're trying to avoid is the last, which is invasive ductal cancer, where you can see that there are lots of abnormal cells inside and both outside of the duct. So, unfortunately, many people get breast cancer. Approximately 64,000 plus had in situ, as I said before, breast cancer in 2013. In terms of invasive or leaving the duct breast cancer, over 230,000 women had it in 2013. And unfortunately, there were approximately 39,000 plus deaths due to breast cancer last year. And this is just in women. Men do get breast cancer, but at a much more infrequent rate. I want to insert a word here about radiation. Now, I have had some people say that they're not going to have mammograms because they don't want radiation because it's going to give them breast cancer. Now, I will tell you that you get radiation just walking down the street, flying in a plane, and the studies that have been done in terms of radiation-induced breast cancer have shown that over time, from age 40 through approximately 70, I think it was in the study, that there was minimally increased, and we're talking less than 0.1% predicted in terms of a person who may get breast cancer. On the other hand, you compare 1 in 8 women get breast cancer regardless just because they have breasts. And so screening has been set up to try to catch the breast cancer early. And if you had to gamble, I would definitely myself gamble on screening versus getting breast cancer from radiation, from a mammogram. So before you even get to the time when you need a mammogram, you should have clinical breast exams. Starting at age 20, you have it about every 3 years, and after that, at age 40, every year have a clinical breast exam when you go see your physician. But you should also do breast self-exams and become familiar with your own breasts so you know whether your breasts are normally smooth, whether they're lumpy bumpy, and that's normal for you, and whether there's a new lump that wasn't there before. You should be acquainted with them. If you have a partner of some sort, he or she may be acquainted with them, but someone needs to know what it feels like so we know when there's something new. So the screening recommendations for average risk women, meaning a woman who has breasts but doesn't have any close relatives with breast cancer, doesn't have any genetic mutations or things like that, should begin their screening mammograms at age 40 and have one yearly. Now, there was something several years ago where people said, oh, you don't really need to have a mammogram until about age 50. And they were looking at the false positive results that come from some of the early screening mammograms. A false positive is, say, when you go get a mammogram, screening, they see something, they call you back, you have a diagnostic mammogram, they still can't figure it out. Maybe you have an ultrasound, maybe you have an MRI, but you end up with a biopsy. And the biopsy results come back as something that is not cancer. That is called a false positive. And although that does cause angst and does cost money, when you look at the cost analysis, there are still modest benefits for survival for people who get breast cancer early, because the earlier breast cancers often are more aggressive, and so you don't want to let them get too far out of the stable. Between ages 50 and 69, there's a clear decrease in the mortality from breast cancer using mammography yearly as screening. Now, after age 70, most major health organizations do recommend that you continue getting an annual mammogram. Now, I will tell people sometimes it's just a personal decision. If your health is so poor that you don't feel that breast cancer is what's going to take your life, then perhaps you need to just deal with what's going on in that other part of your body. But if you are a vibrant 70, 75, 80, 90-year-old, and you think you have enough years ahead of you, you should still get breast cancer screening, because the older you get, your risk continues to increase with time. So let's look at a couple of things that may increase your relative risk. And when I use the term relative risk, I mean if someone's average risk is the number 1, a relative risk is how much basically above 1 something increases your risk, okay? So let's look at the higher risk, greater than 4 as a relative risk. Age 65 plus, although risk increases again after that. Certain genetic mutations, such as the BRCA1, BRCA2, other mutations as well. If you have had lobular carcinoma in situ, if you have radiographically dense breasts, if you have a personal history of breast cancer before age 40, and if you have 2 or more first-degree relatives with breast cancer diagnosed at an early age. Other things that can also increase your risk include a personal history of breast cancer, but over age 40, and you see there, it's not as high of a relative risk as if you had it before age 40. High-dose radiation to your chest, meaning, say you had a disease such as lymphoma, and you had to have external radiation to treat that. Now, that kind of radiation is not the exact same as a mammogram. It's much higher, and it's very concentrated, and it can increase your risk for breast cancer. And also, if you only have 1 first-degree relative with breast cancer, you still have an increased risk, just not as high as the others. Many other things are listed here. I won't go through all of them because I'm sure you can read, and I'll let you know that these lists are at the Susan G. Komen website. So, if you are a high-risk woman, meaning you have BRCA1, BRCA2, some other genetic mutations, a strong family history of breast cancer, a personal history of breast cancer, including both the invasive kind that I showed you or even that in situ kind of cancer. If you've had atypical hyperplasia, meaning not quite cancer, but something is still not right in the duct, or again, that radiation treatment, then these recommendations will apply to you. So again, if you look at the 3 columns, you're going to have clinical breast exam, mammogram, and then possibly MRI mixed in with your mammogram. So if you follow lobular carcinoma in situ or that atypical hyperplasia we talked about, you're going to need a clinical breast exam more frequently. Instead of every year, you get every 6 to 12 months, but you're getting your mammogram every year. And dependent on possible other risk factors, you may include an MRI in your screening schedule. If you're a BRCA1 or 2 mutation carrier or first-degree relative of one of those kinds of people, you break things down dependent upon age, okay? Under age 25, you're still getting a clinical breast exam, which is fine. That doesn't have any radiation, but mammogram is not recommended. Why is that? We'll get into it, but when you're younger, the breast tissue is much denser and it's harder to find things. And so the likelihood of someone picking something up that's useful is much lower in someone who's very young. An MRI is not necessarily recommended. Over age 25, you are going to get still that clinical breast exam every 6 to 12 months, but you're getting your mammogram every year, and you will likely get an MRI every year. Strong family history, again, clinical breast exam more frequently, and if you're over age 25, every year you start having a mammogram 5 to 10 years younger than the youngest person in your family. So if the first-degree relative was 40, you would probably start around age 30 getting a mammogram just because you're at a higher risk. And again, you will likely get an MRI mixed into your screening schedule. Radiation treatment to the chest, like I said, if you are over age 25, more frequent clinical breast exam, and again, you'll get the mammogram every year starting 8 to 10 years after your radiation treatment has happened. Now, you'll get it every 8 to 10 years or at age 25, whichever is least, because there are people who get radiation treatment and they're pre-teens, and so we're not going to start getting mammograms in 18-year-olds or something like that. And MRI can be also employed in their screening regimen. If you have a personal history of breast cancer, every year you get your clinical breast exam, every year you get your mammogram, and very often you will get an MRI mixed into your screening schedule. If you have dense breast tissue, you'll be getting clinical breast exam like a normal person, you'll be getting your mammogram, but they may implement other parts into your screening such as ultrasound and possibly MRI. Some of it is dependent on your insurance. So now I'm going to move to the imaging, what I like to think about most of the day. And I put this in here for many reasons. I think some people think that's what happens, or it may feel like that's what happens, but I promise you they do reinflate if they were already inflated beforehand. So first, the workhorse of screening is mammography. I'm sure nobody really likes it, but it's a necessary evil. So in your picture, you see a square at the top. That's what generates the very low dose radiation. The next piece down is the paddle, which nobody likes, and it comes down and compresses your breast. And then you have a receptor on the bottom that catches the picture, okay? Again, it's low dose. The compression, dependent on whether it's screening or diagnostic, may be bad or close to excruciating. Analog versus digital. Many, many places have digital mammograms, meaning they take the image and it's transmitted directly to a computer where a person such as myself would look at it. Some places still have film radiographs where they will look at them on the view board, and those work. It's just that digital mammography does enhance some parts of looking at mammography. There are some limitations, meaning a mammogram is not perfect. It doesn't pick up necessarily every single thing on Earth, but it does pick up enough to warrant using it, okay? And I have all this in caps, bring your priors. I cannot emphasize enough the importance of having prior mammograms. Now, many people will come and say, oh, can you request my priors? And I sure can, but that does not mean they will send them to me. I would say less than 50% of the time do they send it, unless you as the patient at least call them and say, I would like my mammogram sent to this place, do it. Because I'm not the patient, I can only ask, I can't go get them for you. It's always even better if you bring them with you if you think of it ahead of time. A bit about breast density, since we talked about dense breasts. So you'll see a breast from a side view, and you can tell from the left of the screen to the right of the screen that there's an increasing amount of white in a black background. Now, the more white is the more fibroglandular tissue. The younger people generally have more fibroglandular tissue, and as you lose it, more of it's fat, and things fall slowly but surely. Now, this may not be great cosmetically, but it's great for me because it's very easy to see on the left that I'm looking for something that's white. I'm looking for a mass, which turns up white, or I'm looking for calcifications, which are also white, and they're very easy to see on a black background. When you have a white background, it's harder. So that's what we're saying, extremely dense breasts. That is giving you, increased breast density is giving you a higher risk. A few examples of things I look for on a daily basis. Microcalcifications. You hear all the time about calcifications. You wonder, should I stop taking calcium supplements or something like that? No. Things like that happen regardless of the amount of calcium you're taking in, okay? These would be bad calcifications, meaning they kind of look different. They're not uniform, they're very small, and I try to think of them as kind of crushed salt granules, basically. And these are the ones that I would say, oh, you probably need a biopsy. Now, can anyone tell me what kind of food that looks like? Exactly. Popcorn. Popcorn calcifications make me happy. Make the mammogram very easy to read means that you probably had a little mass in there at some point that's a benign mass. It's very common, called a fibroadenoma. And over time, as your estrogen declines, it kind of just shrivels up like a raisin. And at the same time, it gets calcified. These are big popcorn calcifications, benign. Now this, on the other hand, is a mass, okay? Again, you're looking for something white on a black background, and it's very obvious here that there's a big white blob that shouldn't be there. The edges are all fuzzy looking, and if you see towards the right of that picture, the nipple is even kind of pulled back in. That's nipple retraction, things that clinicians will look for when you're looking for secondary signs of breast cancer. That would get a biopsy. A word about MRI. MRI is a wonderful tool. It is used in high-risk women. Why? Why shouldn't everyone just have an MRI? I get that question a lot. Well, MRI is very, very sensitive, meaning it picks up a lot of things, including cancers, but other things that are not cancer. And if you have to pursue those things, that costs money, that costs people's emotion, and quite often you'll get a false positive. So we reserve it for people who are much more likely to have something wrong, okay? It's also expensive. Ultrasound. Now, I have some people that I don't see, but I see their films come by from year to year, and they have screening ultrasounds because they say, I don't do mammogram. It's okay. Well, it's not appropriate for screening by itself. Unless for some reason they can't get you up there to the mammogram, there's no reason to not have one and just try for an ultrasound. Why? Because those calcifications, those little tiny calcifications, those are the earliest kind of signs of breast cancer. And ultrasound doesn't do too well seeing them. Now, if you have a ton of them, then maybe it'll see them. But at the same time, you probably have an invasive cancer by that time, unfortunately. So sometimes we use it in dense breasts because, yes, all that white background makes it hard to see. And so this gives us kind of a secondary view of what's going on in there, because sometimes ultrasound will pick up things that don't show up very well on mammogram. It's an important tool for distinguishing whether something you see as a mass on mammogram is solid, meaning full of solid material, or is it a cyst? Cysts are benign. Cysts don't need a biopsy. Cysts make people happy because they don't need a biopsy unless they just want it aspirated for pain. So ultrasound has its place, and if you have something that you can actually feel, you should have an ultrasound even if your physician orders a mammogram for you, because it's part of a workup for a palpable, meaning you can feel it, kind of abnormality. A word about tomosynthesis. This is a newer kind of mammogram, okay? So you remember the picture of the original mammogram where there's just the square, the paddle, the breast. Here, that square that's at the top, while your breast is compressed, instead of just staying and taking one picture, takes pictures through an arc, basically. And that arc of pictures, the computer makes kind of like a mini, very, very small CT scan of the breast. Just meaning you can see it layer by layer, so that helps to separate the tissues in the breast and makes things a little easier to see. Some masses stand out better. Areas of architectural distortion, meaning you don't have a mass but the tissue doesn't look right there, those things stand out better. It helps the radiologist to decrease recall rates, meaning if you have this as part of your screening at the time of your screening, and the radiologist can already see that that little area that doesn't exactly look right but isn't too different from before, looks like regular tissue, they're much less likely to call you back to do one of those horrible compression views on. And the dosage is slightly higher for this than a regular mammogram, but it's still within the FDA limits that are put out, okay? So we're not giving you breast cancer with this either. I'll just give you a summary. First, know your own breast. Even though all of healthcare is out there to help you with whatever health issues you may have, you are your own patient. You need to be your own advocate, and you need to know what's going on with your body. When you feel something's wrong, you let your doctor know, and just stand your ground. I've seen patients before where they just insisted, something doesn't feel right, and eventually they were correct. Don't forget to see your doctor, have a clinical breast exam. And if you're having just average risk, meaning you're a woman with breasts with no relatives, no genetic mutations, no other reasons, start your mammograms, get them at 40. Just do it every year. It's a necessary evil, like each birthday is a necessary evil. If you're high risk, you may need something else with your mammograms, but discuss it with your doctor. Please, especially if you come to Loma Linda, bring your prior exams. It makes your life and my life much easier. And again, ultrasound and MRI are adjuncts. They help us with screening, but they are not to replace mammogram unless for some reason you just can't get up to do the mammogram. And we can do them in wheelchairs. So you need a pretty good excuse not to have one. So this is a tomosynthesis mammogram, and you'll see there's regular breast tissue going, this. This is something that you could not see on the regular mammogram. And it just showed up. It looks like a little bow tie pasta. It's not supposed to be there. That's an area of architectural distortion, which, let's see if I can, I don't know how he did it, but believe me.
Move the cursor over the middle of the screen and then do it.
Okay. And this is the side view, and you'll see it come into play. Right there. And this, again, was not seen on a regular mammogram. Turned out to be cancer.
So what made them do that exam if the regular mammogram was fine?
This was part of a tomosynthesis combo, meaning the person had a screening with a tomosynthesis. And so the regular mammogram, just the 2D pictures, the regular pictures didn't show anything, but this picked it up. And so then they had ultrasound, there was a little mass, and they did a biopsy, and it was cancer. So now that's the end. Yes?
Let's say one is an employee of Loma Linda. How would one go about getting the breast cancer gene screening, the BRCA screening?
That's a good segue for my friend Pam Esquivel, who's going to talk about genes. Anything else about screening, mammograms, any of that? Because otherwise I'm going to let her come up.
Tomosynthesis, how frequent, how available is that?
It depends on the place. We have one unit. There are places that have multiple units. If you call wherever you plan to have your mammogram and just ask them, do you have tomosynthesis there? They should be able to tell you. But people who request it, get it. That's it.
I have a question.
Oh.
Does insurance cover screening tomosynthesis?
Let's see. We don't actually get full reimbursement for it as a payment. I think somehow it just kind of gets absolved. And unfortunately, if you're paying for it in cash, they will ask you for money if you're just a cash patient. But if you have insurance, it kind of falls into the slots of Never Never Land, which could be good for you. But I've never had a patient come and say, my insurance didn't pay for tomosynthesis and now I have a bill, but I suppose that's still possible. It just depends on your insurance.